amount of time to do it. But hopefully we did get some interesting discussions from different perspectives and from different priorities. I did sort of go around, and there was some, I think, challenges and wondering about combining some of the traits. And certainly that's something that we can consider. And this process needs to continue post-symposium. So many of you have expressed interest in being part of that process. And so, expect some emails post-symposium. But we don't have time for every individual group leader, unfortunately, in the last 5 minutes to feed back. But if we could just have, if there were particular challenges or particular things that you wanted, points that you wanted to bring up about this, now is your chance. Surely there was some. Please, yeah, Becky, please. We'll get a mic to Becky.
Hi, Anne. Firstly, thanks for all the hard work. I know that a lot has gone into this, so thank you. I think the general feeling in our group was that this was quite difficult. My mic ran out of battery. I'm going to shout. So it was quite difficult to vote on sort of each one to get a consensus, because I think the combining of some things would be really helpful, and there was some confusion maybe between how things were worded. So maybe how a clinician would interpret something versus a social scientist versus a patient. And so possibly combining things and then potentially having an expert or something in that area, a little like we did for voting for where we were going to host.
Yeah.
So with the idea that someone could explain it, because there wasn't really time to explain each trait, that was probably more of a problem for the extrapulmonary list, which was quite extensive, than the behaviour and risks. And I think there was also some confusion that maybe some of the things on the risk factors could also be in extrapulmonary, and whether we needed to split behavioural and risk factors. So I think basically the overall view was it was quite hard to kind of come up with a list without more detail and explanation of each trait.
Yeah. No, that makes sense. No, thank you.
We had a similar discussion, and we suggested that there's quite a few of those that can be actually collapsed. For instance, under a flag of mood disorders, anxiety, depression, cognitive impairment, socialization, a lot of those can be aligned to be tested for easily. Obviously, that would need a bit of more of a discussion, and we also had cardiovascular risk factors that will include a lot of it, or cardiovascular risk screening, and then social support, including substance abuse, financial disability, and stigma. Pain would be one that that can include quite a few. That's kind of, and then you end up with a more manageable amount of traits.
Yeah, I mean, I'll get to Jerry in a sec. I guess the thing that struck me was that, it's really interesting, isn't it, that before this symposium, I wouldn't have thought that there's 92 things that we could do for people with post-tuberculosis lung disease. So I think that in itself is quite, interesting and useful. And so over to Jerry and then to Jamila.
Yeah, so working. There we go. So I think there may need to be an opportunity to talk to you about which ones to collapse, because, for instance, for us with exacerbations of your PTLD, we thought like 4 or 5 of them fell into this is just an exacerbation of your PTLD, so potentially collapsing those. And then the other thing we struggled with from a pulmonary perspective was, one of the things was pulmonary with bronchodilator response, and then the treatment was inhaled corticosteroids, which many of us feel very uncomfortable with, but there's a potential treatability to the obstructive airway disease. It's just we don't agree potentially with the actual treatment that's potentially listed. So we struggled with that one as well.
No, there's different nuance to that. I mean, I guess the other thing that I would say, though, is that we know that people with post-tuberculosis lung disease also have asthma. So do you not treat asthma because someone's had PTLD? So I think it's an open question, but there's a lot of nuance to it. But I appreciate the lack of evidence in that population. Jamila, yes,
yeah,
please.
I guess I agree with what's been said about, I think our group did, about collapsing some of these down. The other really important thing that the group came up with really was that although you may want to ask about certain things and certain characteristics, you need to make sure that then you can do something if you're going to ask about something. And the key example was, of course, socioeconomic challenges or things like food insecurity, weight loss, etc. It's really, I think it could be potentially difficult to ask about that if then there's nothing to link someone to in terms of ongoing care.
So that's what comes back to, what can be done in that setting. So is it applicable to that setting? The list can be customised to the local environment and setting, but it gives options for what's possible. Anna's got the mic, so she's going to get back.
Yes, we were in the I guess, patient perspective group, and what was really evident was that it's not just post-TB lung disease, not thinking about post-TB, it's also thinking about many of these massive manifestations during treatment and actually getting worse during treatment. And many of the consequences post-TB is because of the things that happen during treatment. Some of the perhaps post-traumatic stress that was also due to how care was given. And so really thinking about everything that happens during treatment, ensuring that we're actually dealing with these issues during treatment and not thinking about it until someone has completed treatment.
Absolutely. And the other point that I heard, just quickly, just take one more question before the end of this, is the difference between HIV care and the offering of counselling, and that is not done as routine in TB care. So that was one of the perspectives that I overheard.
I want to be very quick. I think one of the things that we are struggling a little bit with, it's easy to list a potential treatment, but we don't have evidence for a lot of these suggested interventions. And I think one of the prime examples, pulmonary fibrosis, there's antifibrotic treatment. We don't know if it works or not. So
that's absolutely, and that's why you might cross it off the list. Yeah.
Can I just make one comment? I think this is a great exercise because I think that when we look through the literature, we can see that all of these things are things that are reported, my studies included, that we've measured. And I think having this discussion about like what you can really do things about or what matters to the patient or coming to, really thinking about what outcomes we're assessing is really important.
Thank you. So I think we're at time, but obviously this is not the end of this particular work, so there will be lots of discussion and process of fine-tuning this post-symposium, but I think it's been really useful to get that feedback from you all. Becky, yes? Oh, no, so they did already. In the questionnaire and the QR code, the people put in email addresses, and so we've got about so many. So, but if you didn't get that opportunity... Yeah, absolutely. Just reach out to any of the chairs. Yeah. All right. Thanks so much. I've gone 2 minutes over time, so my apologies to Action.
No worries. And the other thing I was just going to say is that we have a sign-up sheet for this part of the workshop. So if you're interested in the treatable traits as well, please feel free to include your name, institution, and email ID. All right. So, All right, so welcome to the last workshop of this really wonderful symposium. We have heard some really exciting talks about post-TB lung disease over the last couple of days. The focus of this part B of the workshop is really to focus on pulmonary outcomes that can be included in all TB clinical trials. And so I won't spend a lot of time with the background since all of you are here. I assume that you agree that this is an important issue. But the goal of this workshop really is to come up with a core set of, or a minimum set of pulmonary endpoints that can be included in all clinical trials, not just HTT trials, but shortening trials, for example, new regimens, therapeutic vaccines, for example. So to try to come up with this set of outcomes which might be of benefit to the larger TB community as well. We have a lot to work through in 1 hour, so obviously. It seems unlikely that we'll reach consensus, but the point here is to get the discussion started, and we will be forming a working group that will continue to work through some of these issues after the symposium. So if you're interested, there are some sign-up sheets which you'll be given within your groups. Please feel free to enter your contact information. In terms of how this workshop is organized, so we are going to have two short talks on clinical trials that are including pulmonary endpoints. And then we'll break up into small groups, the very same groups that you were already in. So if you don't like anyone within your group, please feel free to get up and move to another group. But hopefully that's not the case here. But the same groups, same locations, same facilitators. And then we'll ask one person from your group to summarize your findings or your discussion, and each of you will be assigned a domain to discuss through as part of a clinical trial endpoint. So with that, let's move on to the first talk. Also, we do not have any QR codes here in the session, so we decided to go a little bit old school, so we have paper sheets to sort of include all your responses. So our first talk is by Bob Wallace, who will be presenting in absentia, but he was kind enough to record his talk.
Hi again. I'd like to spend the next 10 minutes or so to talk about trial design and endpoints for TB host-directed therapy trials. And in particular, go over three areas. One of them, patient-reported outcomes. The next bit about FEV1, and then lastly, modeling of the FEV1. So patient-reported outcomes are reports of the status of a patient's health condition that comes directly from the patient without interpretation of the response by a clinician. We are familiar with two of these. One of them, the St. George's Respiratory Questionnaire, and the other one, the TB score, which is one that is a part of the current SMA-TB project. The FDA has issued some guidance about how to use these. The first one came out back in 2009, and it generated quite a bit of interest in the pharma industry at the time, except that afterwards it was followed by almost 15 years of silence, and only in the past year have a bit of specific recommendations come out for use in cancer clinical trials. There really has not been anything in TB, and that's the reason why I want to spend a bit talking about this, not in TB and not in other respiratory illnesses. So this TB score is about half of the information is self-reported. There are some other items that are easily collected. This MUAC is the mid-upper arm circumference. And so each of these generates 1 point. You can get up to 13 points in total. And it was gathered and developed on a series of 700 patients or so in Guinea-Bissau. Its main use has been as a predictor of mortality. And as you can see, they segregated the subjects in this trial into three classes. A low-risk class, which were the scores from 0 to 5, a mid-risk, which is 6 or 7, and then a high-risk group, 8 to 13. And it did work well in this cohort. You can see that the mortality during TB treatment was rather high overall, and that they had a lot of patients. These were three roughly equally sized groups, and there was a surprisingly large number of patients with poor scores, 6s and 7s and 8s and 9s. This score does not track well with other indicators of tuberculosis severity. So for example, if you look at the smear status of all of those patients, they are all in the mid-range, in the 6 to 7 range, regardless of the smear grading. So it's telling us something other than the microbiology. It does get better over time. This is data from SMA-TB across all of the treatment arms. But as you can see, the patients in this cohort are not nearly as sick as the patients were in the original cohort. So here, even at the time of TB diagnosis, the mean scores are only 4.5. So this is a question. I'm not sure that this will be terribly useful as a predictor of mortality or a predictor of other outcomes. Remains to be seen. FEV1, on the other hand, is quite well validated as a predictor of future events, and as a pathway toward drug approvals. And I was curious to look at the history of this a bit, and went back and found the most interesting article dated from 1977 in which FEV1 was measured in a stratified sample of men in West London. Some 800 followed over 8 years. And the authors found that the slopes of groups of a dozen or more men were accurate enough for our analysis. And they grouped those into those with or without mild obstruction at entry. The people who did not have obstruction on entry pretty much stayed where they were over time, whereas the group with mild obstruction, who the authors described as at risk, due apparently to other factors, that depending on how heavily they smoked, their slope in terms of mLs per year got progressively worse with heavier smoking. And they drew up this model showing a decline from normal to death, depending on whether you're susceptible and whether you smoked. And this actually has held up quite well. This study here now is a recent one in the New England Journal showing the distribution of annual rates of change in FEV1 over a 3-year period in some 2,000 patients with COPD. And you can see the mean, these track very well with the data from 1977. And that is the reason why this is such an accepted path for licensing of therapeutics for respiratory indications. People who study COPD are quite lucky in that regard. We are not, because the FEV1 in TB patients is most definitely not a straight line over time. I'm showing here a spaghetti plot from the NAC TB trial. These participants were followed for up to 2 years. And as you can see, many of them had a sharp uptick in FEV1 during the first 2 or 4 weeks of TB treatment. But that many of them reached a maximum sometime during the period of observation and then began to decline. And the longer you look, the more the declines are. So the question is, how do you model this? How do you figure out what to expect from a given patient? You can do a linear model, and this really does not track the data very well. The linear mixed effects model gives a random intercept to each individual patient and then takes the arm and the month and the interaction of arm and month as fixed effects. And this would be interpreted as that the estimate of the slope of the NAC arm was 0.13 units per month, greater than the control, but that this did not reach statistical significance. And I think that's because we're not looking at a straight line. I'm kind of interested in fitting curves to this, and this is a Gaussian 3-parameter curve. It reaches a maximum and then declines after that. It has 2 important components. The variable A determines the peak value of each of the curves, and this value x0 determines the month at which the peak occurs. And so the interpretation of this analysis would be that the estimate for the peak FEV1 value of the NAC arm was 6% greater and occurred 6 months later than the control, but that these did not reach statistical significance. In this case, I think it was because there were relatively few data points at the later time points. What we ended up ultimately doing in this study was what's called a bilinear mixed effects model, which essentially fits 2 straight lines with a hinge. And in our case, the hinge fit best at month 6. And from this one, you would say, well, while on treatment, the NAC arm slope was 0.48 per month greater than the control, and this was statistically significant, and that post-treatment, the 2 slopes did not differ. And I think these 2 approaches can give you a very simple way to present data looking at FEV1 over time, and I would really like to see this applied to a wider range of studies. I think we also can use FEV1 to identify patients who are most likely to benefit. And I'm going to show that here by comparing the baseline FEV1 values to the ones at month 6 in each individual patient. And this, if they were identical, they would fall on the dotted line, this dotted 45-degree line. You can see that in the control arm, the regression curve for all of the data points is quite parallel to the dotted line. And that means that, that from baseline to month 6, all of the participants improved about the same amount. And if you look instead at from baseline to month 12, it's still parallel. It just increases a bit more. And this is quite interesting and also quite an important observation, because if you then go and add the NAC arm in this trial, It's not parallel. The benefit is greatest in the patients who had the most impairment at the start. And over time, that also increased. So from month 6 to month 12, even the most impaired individuals had the greatest improvement. And this means that the NAC benefit is greatest for those with the greatest baseline impairment, and that stratified treatment and stratified trials can improve cost effectiveness and help you to get the most information from the smallest study. It is somewhat challenging to do spirometry at the time of TB diagnosis, but not out of the question. This is one of the setups that we have used at one of Orum's sites in South Africa. This is a relatively inexpensive plexiglass booth. It has an air exhaust with a hose that carries air from the booth out of the window. And the operator can seat in front of the computer and have full view of the computer, the spirette, and the patient. So it can be done safely and accurately. So just to summarize, patient-reported outcomes, interesting, but in my opinion, unlikely to provide compelling evidence for adoption of a new intervention. FEV1, critical to identify patients most likely to benefit and to measure the extent of that benefit. And then finally, modeling, also critical to understand trajectories and to maximize the values of small trials. Thank you.
All right, and so moving on to the next one, here I'll be presenting a little bit about the TB Pure trial, which is a pulmonary rehab trial to prevent post-TB morbidity. Again, I won't be focusing on the rationale or study design, but more on the outcomes, and hopefully transparently discussing some of the challenges and considerations we worked through to select our endpoints and structure the study protocol. So this is an individual randomized phase 3 hybrid effectiveness implementation trial. So in addition to testing the effectiveness of the intervention, we're also collecting some data on feasibility and scalability within our population. This trial will be done at 4 clinical sites in India among adults with confirmed drug-sensitive pulmonary tuberculosis who have a baseline MMRC score of 1 point or higher. They will be enrolled and randomized at treatment initiation. The intervention here is a home-based pulmonary rehab program that started at treatment initiation. So at beginning of the therapy, we have 3 arms. So the first arm is a short arm, so that's 8 weeks of pulmonary rehab. The second arm is an extended arm, so that's 24 weeks of rehab. And the controls is a standard of care arm with some PTLD counseling. The sample size is 690 individuals. So who would be randomized in a 1:1 ratio into the 3 study arms. The study PIs were Jonathan Golub, who you see there, and myself will be blinded because we don't trust each other. And our biostatistician will also be blinded because we don't trust him either. We do have an independent DSMB that will be monitoring this trial. So our hypothesis here is that pulmonary rehab during therapy will prevent inactivity-associated deconditioning and accelerate improvements in respiratory health during therapy and have some sustained benefit during the post-treatment phase. And so this figure summarizes our hypotheses and our trial design. So we have these 3 arms. We expect that the intervention will lead to dramatic improvements during the first 2 months of therapy. The extended arm will continue this improvement during the so between month 2 and month 6, and that will lead to some sustained benefit during the post-treatment phase. Our primary endpoint will be assessed at month 12, so that's 48 weeks after randomization. Our primary endpoint here is the mean difference in the 6-minute walk test distance that's compared between the 3 arms at 48 weeks of randomization. This will be evaluated by an independent and blinded assessor. Our secondary endpoints are lung function and respiratory questionnaire scores. We will analyze these, again, by comparing between arm differences, but also looking at the change in these parameters from baseline to end of intervention and sort of comparing the difference in improvement between our study arms. And our study is powered to detect a 30-meter or greater improvement or difference, in the 6-minute walk test distance between the arms, and we adjusted our type 1 error rate because we are simultaneously comparing 3 of our study arms here. So there are several outcomes that we could have selected, right? So why did we choose the ones that we did. And many of our colleagues from within this room have advocated for including pulmonary endpoints in routine TB clinical trials. We have also provided a conceptual framework for sort of thinking through some of these outcomes across various domains. So the first one was really selection of our outcome. We ended up with the 6-minute walk test because really it's an excellent test to measure functional impairment. It's a submaximal test. Most routine activities are performed at the submaximal level, and so this test really measures that. It's commonly used for clinical trials and pulmonary rehab. That's what we expect would improve with our intervention. It's extensively used, objective, validated, it's standardized, and it really has a strong association with mortality and hospitalization risk. But it does have some limitations. The first one is that it's not a specific test, so it can detect impairments in cardiovascular or neuromuscular systems as well. And second is that it's prone to a ceiling effect. So what that means is many of these tests have sort of a physiological limit of detection, upper limit of detection. And so patients who have more impairment, they just have more outcome to gain as compared to those who sort of enter with mild to moderate levels of impairment. So many tests, including lung function, are prone to this sort of this ceiling effect here. The other outcomes that we considered were lung function and respiratory quality of life questionnaires. We went back and forth, but we decided to use the 6-minute walk test. The data around improvement in lung function with pulmonary rehab are inconsistent. Some studies have shown improvement, others have not. With the questionnaire scores, we decided to include those as secondary endpoints for our particular study. The second key challenge was when to assess our outcome. And this really is critical because as we have already heard, so respiratory health status, it continues to improve during 6 months of therapy. It likely continues to improve maybe about a year and a half post-treatment as well. And so when do we really measure our trial endpoints? At treatment completion, that's probably too early. We may not be able to capture the persistence in impairment. And so we sort of wanted to consider that as well. The second key issue is really the durability of pulmonary rehab. So from many prior trials, we know that pulmonary rehab is effective as long as you take it. When you stop, the benefit seems to wane in about 3 to 6 months. Now, there is sort of this behavioral change component associated to it. We heard that, I believe, in yesterday's talk, where many of the individuals, once they start, even though their intervention stops, they like it and they continue. But unless these individuals take it, it does not seem to have sustained clinical benefit. And so considering these 2 points, we decided to have our primary endpoint at 6 months post-treatment completion. Now again, all of us would love to have long follow-up, but clinical trials are funded by sponsors. They do require that we report our results in 3 to 5 years. So factoring all of that in, the time that it takes to get regulatory approval, set up your study, complete your recruitments, it's challenging to have really long-term outcomes. So balancing all those factors, we ended up with 6 months post-treatment. Challenge 3, how do we analyze our primary endpoint? So you've heard about some interesting modeling approaches from Bob Wallace's talk earlier. In general, there are sort of 2 broad approaches to analyze these data. The first is what you would call a landmark analysis. This is what the FDA recommends. Just simply because it's easy to interpret, and this is just comparing the difference in your outcomes between arms at a pre-specified time point. But the other approach, which is the difference in difference approach, is sort of measuring the change in your outcome from randomization to end of intervention or to some particular time frame. And this may have some key advantages. So first is that it probably captures trajectories or evolving outcomes a little bit better. It's also easier to apply minimum clinically important differences. So MCIDs, they are developed for within individual change over time. We apply them to between-arm differences, assuming that because we randomize, these individuals are counterfactuals of each other, right? Which is somewhat a strong assumption. So if you look at this difference in difference approach, we're actually applying MCIDs to within-person change and comparing those differences between arms. So a slightly different way of thinking about this. This approach also may be less prone to ceiling effects that we just discussed, and also can overcome differences in baseline randomization if they do exist. So we ended up with the landmark analyses, again, just because it's easier and it's simpler and it's easier to interpret. But the difference in difference approach is our secondary analytic method in our trial. Last one, sample size estimation. We unfortunately do not have MCIDs for TB, unfortunately. We do have them for other chronic lung diseases, but I think this is a key knowledge gap. Unless we know what difference is meaningful, it's hard to power clinical trials to detect that level of difference. Also, there's really high variability associated with many of these measures, since lung function, 6-minute walk test distance, and so on are constantly evolving. They're changing, they're improving during 6 months of therapy and thereafter. So accounting for that variability can be challenging when you consider your sample size estimation. Again, your analytic approach does influence your sample size calculation. So comparing a mean between arms is different from comparing, let's say, the proportion of individuals who experience a meaningful improvement between those arms. So very different approaches. And the last point is really important, because whether you should use the absolute measures or z-score standardized or percent of predicted outcomes. And where possible, the absolute outcomes are preferred because it sort of gets rid of this uncertainty of which reference equation is being used to standardize. But having said that, a percent predicted or z-score approach is statistically favorable. So you typically need smaller sample sizes to detect a difference in percent of predicted approach. Unfortunately, all the MCIDs that we have for other lung diseases, they have been measured for absolute differences. So those are sort of some considerations. Hopefully I've given you a flavor of what we, of some of the challenges and other key issues that we went through. So before I describe the small group discussion, Brian.
So just a quick question. Are you asking us for endpoints of clinical trials of acute TB start to finish, or clinical trials after TB and post-TB? Because I think there's slightly nuance and difference. Which of those questions are you asking us to discuss?
Great question. So we intentionally left that a little vague, but what we are hoping to do is come up with a core set of outcomes that can be included in all TB trials. So the focus here is really during the acute phase. All TB and post-TB trials, but focusing really on the acute phase, so during the 6 months. So this hopefully would be helpful for other clinical trials, not just HTT trials, but say treatment shortening trials as well. So yes, we will be breaking up into the same groups that you initially were. I keep forgetting the animals that you were in, but we have chimpanzees who are now group 1. So you will be assigned lung function. We have whales, functional status, penguins, patient-reported outcomes, bears, lung imaging, and tigers, healthcare utilization. I'm going to use the chair's prerogative, and I'm going to assign Brian to healthcare utilization, given our discussion about exacerbations. But what we are hoping to do here is to have you focus on 3 key questions. First is, should your domain be used as an outcome for TB clinical trials? Second is, if yes, how should it be measured? And third, when should it be measured? If you have more time, 2 optional questions to consider. What do you think would constitute a meaningful difference in those outcomes? And surrogate endpoints for perhaps early phase trials or phase 2 trials, which we can also consider. So with that, you have 20 minutes, and then we'll regroup here for a summary for 10 minutes, where each group will have 2 minutes to present their findings. Good luck. Oh, yeah.